My area of specialty is hearing and balance. That was a really nice introduction. Thank you. I am a fairly specialized person. I do a lot of surgery for hearing and balance issues. But this morning, we're going to talk about hearing loss and some of the implications for hearing and balance. I do a lot of research. I have some federally grant-funded research. We also do research with a variety of implanted device manufacturers and some other intraoperative tech, such as imaging, et cetera. So what about this morning? This morning, we are going to talk about the epidemiology and pathophysiology of hearing loss. And we're going to talk a lot about noise-induced occupational exposures. And the nice thing about talking about that is it has a great overlap with hearing loss of aging, and we'll go through that. But the implications for noise-induced hearing loss really apply far outside occupational exposures. They apply to kids, middle age, really everyone, and I'll show you some data to support that. Then we're going to spend some time talking about the association between hearing loss and health and function, and we may learn some things that are a bit surprising in terms of what hearing loss is related to. As far as a number of other health metrics and diseases. And then we're going to talk about treatment and the full range of treatment, including my favorite treatment, which is, of course, prevention of hearing loss and noise-induced hearing loss, if possible. So we're just going to jump right in. I have lots of facts. I can impress you with all kinds of important details and impressive facts about hearing loss. And that's because hearing loss is really so incredibly prevalent. This is from the recent WHO report on hearing, which happens every few years and happened in 2021. So 466 million people in the world experience hearing loss. Of course, that number is going to grow to 900 million by 2050, they suggest. And over 1 billion people, young people between the ages of 12 and 35 worldwide, are at risk of hearing loss due to noise exposure. How about the data in the US? Well, hearing loss is incredibly common. 2/3 of US adults over the age of 70 years old have hearing loss. So if you're seeing anyone in your office or your clinics who are over this age, the high likelihood is that they have hearing loss. And that's true for our family members, our neighbors, our friends as well. In fact, hearing loss is the third most common physical condition of adulthood. That's outweighing both diabetes and cancer. So incredibly prevalent. Now, we all know that aging of America is happening, and so there's more severe hearing loss as the population is aging. The portion of individuals, as you can see by this graph, the proportion of individuals who are over the age of 80 who have severe hearing loss is growing. So let's talk about some statistics for occupational noise exposure. 25% of all workers have been exposed to hazardous noise, with 22 million exposed per year. And a great portion, more than half, report not wearing hearing protection. For me, this is very common. Probably you also walk around New York and see various individuals, either for the Department of Transportation or other things, who are not wearing hearing protection when they're clearly doing very loud things. That's true really nationwide, with more than half of individuals not wearing hearing protection. Data suggests that 8% of all workers have tinnitus. Most of us think this is highly underreported. This statistic refers to those individuals who have disabling tinnitus. We're going to talk a little bit about tinnitus this morning, but certainly happy to hear any questions or discuss more about that. Disabling tinnitus are those individuals who really feel that this is a problem for their life. And actually, just the prevalence of tinnitus is much higher because it's very closely related to hearing loss in general. So 20% of noise-exposed tested workers have hearing loss that impacts day-to-day activities. We're going to talk a little more about what that is, but basically that means pretty significant or severe hearing loss. So where do these statistics come from? Well, these statistics come from the National Institute of Occupational Safety and Health, from the Occupational Hearing Loss Surveillance Program. So this collects worker audiograms, which analyze and give them data about what's happening in a variety of industries across the US, and they can generate statistics from this. And it's really an incredible reservoir of data specifically relating to occupational noise exposure. They have over 1.3 million audiograms. And from this data that's been in place since the mid-80s, I believe, there's clearly hearing loss in all industries. So really all workers have the potential and are at risk for noise exposure. You can see in this graph to the right, overall, this is going down over time. The last time this was analyzed was quite a long time ago as far as the risk of incident hearing loss. The one on the left is the most recent publication, just in 2024, talking about noise exposure amongst utility workers, which are people that work in like steam and air conditioning and power plants, et cetera. Not surprisingly, there are a variety of industries that have a large degree of hearing loss. Some of them seem very obvious: construction, mining, manufacturing. Other ones traditionally low, such as finance and insurance. In fact, healthcare workers were previously thought to be very low and now are coming up to the middle of that pack. So really widespread in general. Let's talk a little bit about noise and what noise are we talking about? Well, this is a nice heat map that gives noise level of common sounds. Every time I give this talk, I try to put a little variety of things in there. And I think talking to a group of New Yorkers, no one is going to be surprised with some of my examples. Our world and the world of New York City is incredibly noisy. So I'll call your attention to 85 decibels. 85 is something we're going to talk about in a slide or two. But when the noise reaches 85 decibels, you have to raise your voice to be heard by someone 3 feet away. That's pretty close. If you have to shout to be heard by someone 3 feet away, then typically that level of noise is about 95 decibels. Now, most restaurants, this was a long-standing fact, that most restaurants were in the 70s, anywhere from about 75 to 77 decibels in loudness, roughly the level of some city traffic. But there's been a lot of really fun data that's come out. I'm sure anyone on this call who's been to a restaurant in New York City, or maybe anywhere, but definitely in New York City, would not be surprised to find that most restaurants are much louder than this. The New York Times has done this quite a few times. Most recently, they went to the Standard Hotel. I think in Tribeca, they measured their restaurant noise, which was 95 decibels. This is an article from the Washington Post just this week, where someone is looking at the noise level of restaurants in Washington, D.C. So in fact, the noise level of restaurants can be quite high. I'm definitely dating myself here, but the Zagat Guide even had something for noisy restaurants that they also included. So that can be important, because hearing in background noise is quite difficult and specifically related to a type of hearing loss we're going to refer to. All right. So I also, this is something near and dear to nearly all of our hearts, AirPods. The max decibels that AirPods can get to is 110 decibels. That's pretty loud. You can see on the graph they're related to a leaf blower. There's lots of things that Apple Health actually does, and it's also something I'm happy to answer questions about or talk to about different hearing controls you can put on your AirPods, or actually the AirPods of kids in your family or others that can control to make sure that they're not exposing themselves to this volume. How about another topic near and dear to our heart? Well, perhaps even if you're on site today at Mount Sinai or somewhere, you may have heard an ambulance. You may have been stuck in a narrow street where an ambulance, such as a Mount Sinai ambulance, was trying to go by, and in fact felt the loudness and the pressure. Well, typically ambulance, there has been a lot of data on this, specifically at Mount Sinai, actually. Their Mount Sinai ambulances were at one point tracked to be as loud as 130 decibels, the siren. This is, as you can see on my graph, a jet taking off. There was a group in the Upper West Side called Serenity that actually petitioned the city council to change, and there is now a passed law regarding the volume of sirens, and the emergency services of Mount Sinai were one of the first in the city to pioneer and start changing the decibels of their ambulances prior to this change in New York City. You can see at the bottom there, just in August of last year, some of the sirens are actually changing to that sort of European woo woo sound, which is actually a little better. But you can see just on a day-to-day life for anyone, including someone who works at Mount Sinai, we can get a fair amount of noise exposure. So I brought your attention to the 85 number. The U.S. Department of Labor and the National Institute of Occupational Safety and Health consider 85 decibels the limit of safe occupational noise exposure, such that hearing protection is typically required above 85 decibels. Now, the risk of hearing loss is related to how loud, which we just spent a whole bunch of time discussing loud sounds, but also how long the exposure lasts and how often it is repeated. So here are exposure level that talks about the time frame between the two. So 85 decibels averaged over an 8-hour workday is the level at which, whether workers are exposed to that noise level or above, they are at risk of developing significant hearing loss over their working lifetime. As that number goes up from 85, actually it decreases in half the amount of time. You can see by that diagram, as you get down to even the loudest ones, there's a very short amount of time that you could be exposed to give you significant risk. Now, it's very important to recognize that everyone, every individual differs in their susceptibility to noise. A lot of those differences may come from genetic differences, inherent hearing loss that they may or may not have, their prior exposure to medications, ear infections, ear health, other medications that they're taking, disease processes, their other comorbidities. There's really a myriad of medical conditions that can make each individual susceptible in a different way to various types of noise exposure. So this always seemed like a really obvious slide, but this is actually one of the most subtle aspects of my practice and one of the most important things that I find talking to other people about, which is that the symptom of hearing loss is very rarely hearing less. In fact, I see hearing loss as a routine, as do most of my colleagues in ENT. And in fact, very few people say that they can't hear. And part of that is because hearing loss is predominantly progressive, insidious. It's often bilateral and oftentimes symmetric. Most people describe a difficult time hearing in background noise. A large amount of people describe that something is stuck in their ear. If they could only just remove that, if something could just be removed, that they could hear better. And most people say, well, don't I have wax in my ear? Isn't there something there that's blocking their hearing? And that feeling of blockage is the symptom of hearing loss. Many, many people also say, well, people mumble. And frankly, people do mumble, but if your patients or individuals having consistent difficulty with that, where they obviously know someone is talking, but they're losing clarity, they can hear what they're saying, but they don't understand the words. These are symptoms, the most common symptoms of hearing loss. Again, tinnitus, ringing or shushing sound, a noise that someone's hearing that does not come from the outside world. This is also an extremely common symptom of hearing loss. So the last one I mentioned, because this is something that people talk about in some of the occupational noise exposure, is if individuals at the end of the workday may not even notice that they are experiencing a threshold shift or some subtle noise-induced hearing loss. So one of the old teachings that we used to have in this area was people would turn the volume of their car radio up on their way home from work. So if patients are telling you, or you could even ask a worker who you may be suspicious or who's reported some noise exposure, if when they get into the car in the morning, is their radio too loud? The same is true to some degree for AirPods or any kind of monitor that they're then doing after a nighttime of rest. So what's being described there is a threshold shift, and we're going to be going over that in just a few slides. But before we get to that, this is the point that I usually like to just bring back a couple small pieces of anatomy. I am a surgeon after all, so I really can't get away from the anatomy portion. And this is the auditory pathway. And I promise it will have some relatability. So obviously the ear sound comes down your ear canal, vibrates your eardrum, then it goes through these three bones of hearing, and this vibration creates a fluid wave within the cochlea that signals along the auditory nerve, which is then taken the rest of the way through the auditory cortex and up to the brain. So there are a couple types of hearing loss, essentially two. The first one is a conductive loss. This is related to blockage in the outer part of the ear canal, wax very commonly, as mentioned, otitis externa, etc., as well as middle ear problems, ear infections, hole in the eardrum, problems with your bones of hearing, etc. So those are all types of conductive loss. The second kind is sensory neural hearing loss. That involves the cochlea, the auditory nerve, and all the way up the central pathway. Now, of course, you could have both. You could have age-related hearing loss or sensory neural hearing loss and also have an ear infection or a hole in your eardrum. And in those cases, of course, we call it mixed. Now, noise-induced hearing loss, age-related hearing loss, ototoxic hearing loss, all of these kinds of hearing loss we're going to be delving into fall into the category of sensory neural hearing loss. And not only into that category, but specifically to the level of the cochlea. Now, I spend a lot of my time thinking about operating on, etc., on the cochlea, so you'll forgive me for a few cellular slides here. But 90% of hearing loss occurs at the level of the cochlea. So this is the cochlea here, meaning snail. This is a cross section at the bottom. And basically what's happening in the cochlea is that there is something called the organ of Corti where an important hair cell lives. Now, actually, a lot of people have heard about hair cells. Those are the tiny little cells with cilia that are embedded in a gel membrane above. And each time that fluid shift comes there, it causes movement of the hair cells within the tectorial membrane, the cilia, and that leads to a change in electrolytes, which then depolarizes the nerve. So it is literally at that location that acoustic sound is translated to electrical impulses. And it is at this location, the loss of both the inner and the outer hair cells that lead to hearing loss. So the cochlea is pretty amazing for a couple reasons. Number one, it's tonotopically organized. What that means is different hair cells are linked to specific frequencies, almost like keys on a piano. You can see on the animation here, when the cochlea is unrolled and theoretically, as it's unrolled, you can imagine different cells associated with different specific frequencies like seen here on the piano key. And in fact, at the base of the cochlea is where the high frequencies are located. And at the apex or the top of the cochlea is where the low frequencies are located. And it's some pretty amazing physical properties of the basilar membrane that allow these different frequencies to attain different amplitudes and allow for some of the specificity of this tonotopic organization. Now, how do we tell? How can one tell? I mentioned earlier that, of course, people have different symptoms of hearing loss, and obviously, or often, it's not just I'm hearing less. So we test it using behavioral audiometry. This is a diagram here of a audiogram. This is performed in a soundproof booth. This is sort of our standard comprehensive audiometry, which is the gold standard, and it's performed by an audiologist. Loudness in decibels on a logarithmic scale is on the y-axis, and the different frequencies are there along the x-axis. A comprehensive audiometry can tell not only what kind of hearing loss, as mentioned before, conductive, sensory neural, or perhaps a combination of both, but it also goes into a ton of measurements about middle ear volume, vibration of the tympanic membrane, as well as speech audiometry, which helps us figure out how well people are hearing, and we can do that both in quiet environments and in standardized background noise. And this gives us a lot of very objective data about what an individual may be hearing that can be compared. Now, Why did I spend all of that time? I mean, that may be a question we can't answer, but the point of telling you a lot about how the cochlea works and what those important things about tonotopic organization is that it explains a lot of what's going on. So in noise-induced hearing loss and also in age-related hearing loss, it predominantly affects the high frequencies. Now, why is that? Well, mostly that's because these high frequencies are right where the bones of hearing connect to the cochlea. So you can imagine if there's a big blast or a big noise, that tympanic membrane has a huge excursion, creating essentially a tidal wave within the cochlea that then shears off those ciliated cells, causing damage to the hair cells, such that the hearing loss is localized primarily to the high frequencies. Now, I'm a surgeon and relatively simple, so I think a lot about this in the mechanical, exactly as I described, the shearing forces. But there's a tremendous amount of basic science that actually talks about noise-induced hearing loss and the variety of issues they have with that they can cause on both the molecular level with noise causing proapoptotic cascades and other things. So it's not purely a mechanical issue. There's metabolic changes and a lot of other changes on the cellular level that contribute to noise-induced hearing loss and the mechanism. But in many ways, a lifetime of this is also what is believed to be underlying a lot of age-related hearing loss, and I'll show you that here. On the left side of the screen is a really old but very well-known study from the 90s that looked at noise-induced hearing loss among workers in Scandinavia, soldiers, etc. The top graph is 5 to 10 years, and the last one is really over a lifetime, 40 years. And you can see here that in the low frequencies, again, this is at the top of the cochlea, in the low frequencies, the hearing is pretty normal. 20 to 25 is considered normal by WHO standards. And a lot of the hearing loss is localized to the high frequencies, and the same is true over time. This is just a picture of age-related hearing loss at different ages. We mentioned that 2/3 of individuals over the age of 70 have some hearing loss. And again, you can see how these two are very similar in where the hearing loss is localized. What about more acute hearing loss? And this comes to something called a threshold shift. So typically, I don't know if anyone on this call has ever had their ears feel a little bit funny, like there's cotton in them, there's something stuck, maybe a shushing sound after exposure to loud noise. So this has often been described as after a concert, etc. Definitely, it's still and traditionally can happen at a concert. I find a lot of this also happens to people just in daily life. Like, for example, frequently it occurs when an event is not intended to happen in a non-concert venue. Like a great example, someone I saw this week, the fourth grade band concert at his elementary school was supposed to happen in the auditorium, but there was a leak or something. So they moved it to the cafeteria, which had really low ceilings. And so actually the acoustic trauma that they were exposed to during, just a routine fourth grade band concert was actually quite dramatic and caused a threshold shift in this particular patient. But it doesn't always have to be a shotgun blast or something like a concert. I caution a lot of individuals, and I would mention to you all, if you're going to see a concert or a musical event that is not in a typical concert venue, like not at Lincoln Center, but maybe like in the basement in the East Village or something to that extent, that's often when a lot of these acoustic traumas can occur. So this is a graph from a mouse experiment at the NIH by one of the preeminent physician scientists. Actually, I think she's just a PhD, but in her lab is also a physician scientist at the NIH. And they exposed mice without any known genetic deficits to loud noise for 2 hours. So 100 decibels for 2 hours. And this was a control group of unexposed mice. This was 1 day after. This is showing the change in threshold. And then 2 weeks after, right back to the unexposed group. So a temporary threshold shift comes back. It recovers to baseline. When they looked at the cellular level of a temporary threshold shift, they found that there actually were some molecular changes. There is some synaptic changes that can occur, but there was no hair cell loss, no hair cell death, or overall global gross changes to the hair cells. Now, there's lots of different things that could affect why a particular noise trauma might cause a temporary threshold shift in one individual and a permanent one in another. Some of those, of course, are what we've discussed: the volume, the time, and then a ton of patient-related factors, including their genotype, pre-existing hearing loss, other comorbidities, and including things like whether they smoke and other things. Now, a permanent threshold shift, this is the side of that graph where these mice, same, were exposed to 4 hours. And in this case, again, they had the same change 1 day after the noise exposure, but by 2 weeks, they had not come back to normal. This is what's considered a permanent threshold shift. This is when, after an acute noise-induced hearing loss, the hearing does not recover. Regulatory bodies such as OSHA and others have definitions of what they consider to be a permanent threshold shift, including the amount of change in decibels and at which specific frequency. When this is seen on a molecular level, this is where the hair cell damage, the permanent change to the organ of Corti that we talked about before, that really never recovers. So the vast majority of hearing loss, not all, and we could talk about that separately, but all noise-induced hearing loss that is permanent usually does not recover. And of course, this is really prevalent in literature, including the New York Times and plenty of other things, rock stars, those individuals who were at those concerts and not using hearing protection. I think there was just an article in the New York Times not long ago about Paul Simon, but others, young people as well. It's really quite rampant noise-induced hearing loss, something that often many of these musicians are talking about as well. So what happens if someone that one of your patients, etc., they report this happening? Well, the first thing that someone wants to do if they've had, or yourself, your ears feel funny after an event you think you may have had, or a patient may have had noise-induced hearing loss, well, you want to make sure they don't have additional exposure. We were talking about it's not just the noise, but how often. So try to put them in a quiet environment, have them not do any additional exposure to loud noise, no using AirPods, etc., until their hearing recovers. Everyone, of course, would like to see them in the office and get an audiologic evaluation. We can track often at the time. We don't know if it's going to be temporary or permanent. The time frame tells us that a little bit, such as within a few days, and 3 weeks is the global period that we often think about. But there is the art of medicine in there as well. But the treatment is oral steroids. So individuals that have a sudden hearing loss, whether that be due to idiopathic, viral induced, or noise induced, we treat them with oral steroids. This is the typical regimen that we use in ENT, which is 60 milligrams per day, up to 7 days, and then a taper. These individuals can also get intratympanic injections. It's something that I do in my office quite frequently, like multiple times on a given day, because we are often seeing individuals that may need that, and we inject steroids directly into their ear so that it can go and be absorbed directly into the cochlea. There have been a few other things that have been described for noise-induced hearing loss, such as hyperbaric oxygen. We also encourage people to have a low salt diet if possible at the time, not have a lot of salty foods, make sure they're fairly hydrated, and minimize alcohol in this period of time. So what else can be done? People often ask me, platelet-rich plasma, what are the other treatments for this? Well, this is actually a really recent article. I'm going to go through everything on this. No, I'm just kidding. I'm definitely not. I put this on there, which is just to demonstrate that there's a lot that's known about a ton of signaling pathways within the inner ear, reactive oxygen species, etc. And there are numerous studies going on for noise-induced hearing loss, for hearing loss in general. Sadly, this is the clinical candidates from that same article. And as you can see, there's quite a lot in preclinical and not as many moving out to the clinics. As currently, today, at present, there is no clinically available medication or intervention for noise-induced hearing loss or really any hearing loss beyond steroids, both oral and intratympanic, which I mentioned on the prior slide. I'm going to take a breath here and just put this single slide up. This is a ton of information, and I felt like I really had to mention it, and that's ototoxicity. So hearing loss and hearing imbalance disorders can be caused by ototoxic chemicals. Tons of medications have this potential, even things like aspirin. Obviously, people are taking this all the time for various things. So really, we think about aminoglycosides and chemotherapeutic agents. There are some individuals that are especially predisposed to medication-induced ototoxicity, and that is permanent hearing loss, typically vestibular issues as well. And I bring it up in this particular lecture only because it has been documented in the occupational and environmental exposures as well. This is much, much less common, harder to diagnose, but for individuals that do have jobs that expose them to a variety of chemicals, that can compound noise-induced hearing loss. So those individuals are at even greater risk. Okay. Let's transition now to the second part where we're going to talk about whether hearing loss is related to other health conditions. And surprise, it's related to a ton of health conditions. And we're just going to kind of go through this to give you an overview. This is also a large body of research and a large body of data, which is increasing all the time. So specifically, I will say cardiovascular disease and occupational noise exposure is a pretty well-researched area. It's clear that occupational noise exposure, so noise exposure over 85 decibels for more than eight hours per day, is specifically related to increased risk of cardiovascular disease. Lots of studies, both clinical and basic science, have found that this is probably because chronic noise-induced or chronic noise or loud decibels induce stress hormones causing inflammatory cascades, which lead to a variety of cardiovascular pathophysiology, such as hardening of vessels and hypertension, etc. So clearly hearing loss is related to cardiovascular disease. It's also related to dementia and cognition. And this is an area that is really become more and more flushed out and is absolutely fascinating. Back in 2011, some of the earliest studies occurred showing that not only are individuals with hearing loss at risk for dementia, at unique risk, but in fact, there's a linear relationship where individuals with more hearing loss are at greater risk. Over time, this data has blossomed the world over, different populations throughout the world, a lot of studies within the US. This is now pretty much believed to be extremely well established that hearing loss is associated with cognitive decline and dementia. This is a meta-analysis from 2018, a really well done one. There's obviously a ton of disparate measurements. We're not even going to talk about that. Sometimes people with hearing loss aren't appropriate for normal cognitive measures, but looking at all of the studies, it is clear that all of the data points to the fact that hearing loss is a risk factor for cognitive decline and dementia. And all of these studies suggest that those with more hearing loss are at greater risk. So much so that the Lancet Council on Dementia Prevention, Intervention, and Care, which came out in 2017 and then again in 2020, identified hearing loss as the most important modifiable midlife risk factor for dementia. On the right there, you can see the percentage of reduction if the risk is eliminated. Smoking is 5%, hearing loss 9%. So really taking this data into how we can encourage individuals to get treatment because we know this risk is really significant. This one seems a little more intuitive. hearing loss leads to social isolation and depression. For every 10 decibel drop in hearing, the odds of social isolation increase by almost 50%. So this data is abundant as well, and also sort of makes sense in lots of ways, I think, to us. So originally, when the data came out, they proposed this conceptual model. I find looking at this really helps me think about how these things may be related because it makes a lot of sense. So the first one is related to cognitive load and attention. And that's the idea that when you have hearing loss, you're really concentrating to hear what someone is saying. I mentioned earlier, it's not that you're hearing less, it's that the clarity is lost. And so you're really using a lot of your attention and cognitive resources, you're diverting them to listening effort. And in fact, that's taking something away from memory and from other areas. So this cognitive load is one hypothesis. Another one relates to socialization. If you are hearing loss leads to decreased socialization, which we know it does, that has a cascade of implications for dementia and cognitive decline. The last one is perhaps there are pathophysiologic changes that are shared by the aging brain and hearing loss that can lead to dementia, or perhaps there are even changes just from hearing loss itself. And that's particular changes in brain structure and function is now being even more looked at, where hearing loss is associated with reduced volume in the auditory cortex and accelerated decline in various areas of the brain. And these are hearing loss independently. And all of these studies are really able, either from their study design or others, to control for a lot of the other factors that are related to hearing loss. Hearing loss is also related to physical function and falls. So adults with hearing loss have a 63% increased risk of falls compared to those with normal hearing. And spoiler, it's related to the degree of hearing loss. Individuals with more hearing loss have a greater risk of falls. This is a particular area of research of mine, and I have some federally funded studies that look into this, and I'm happy to talk more about the relationship between hearing loss, falls, and physical function if anyone is interested. So that brings us to the last part, which is, I just went through a ton of things about hearing loss, implications for health and function. Well, does treatment impact those conditions? Well, prior to literally this summer, when I used to give this talk, I would say we're all waiting for the ACHIEVE trial results, but thankfully they are out. So I don't know if anyone has heard of this, but the ACHIEVE trial was a randomized control trial. It was run out of Hopkins, where they randomized adults between the age of 70 and 84 to receive hearing aids or a successful aging intervention, and they followed them for 3 years. The data is really all throughout this year, and so much more data to come about the variety of things that they measured in this study. The first thing they published, which was one of the things we were all so excited about, was the cognitive data. And so in this study, over a 3-year period, they demonstrated that hearing intervention, hearing aids in this case, can reduce cognitive change within 3 years for those adults who are at risk for cognitive decline. So those individuals that were at risk had cardiovascular and other risk factors that put them at risk for cognitive decline, and hearing aids helped. They reduced it significantly, and in that short time. Now, actually, this data has been apparent in the cochlear implant literature for even long before that, which is those individuals that are at highest risk. I mentioned earlier about the linear relationship. Cochlear implants are for individuals with severe hearing loss. Those individuals who receive cochlear implants, that has a significant impact on the risk and the development of cognitive decline, and even for those individuals with mild cognitive impairment. We're going to talk a little bit about why there's more data in the cochlear implant literature than the hearing aid literature in just a second. So now this is my area of expertise, the myriad of treatments for hearing loss. We're going to talk about those really briefly. We all know about hearing aids. Over-the-counter hearing aids are for mild to moderate hearing loss. An individual can go into Best Buy. You can buy them on a variety of other locations, a lot of it online, when you don't need a physician note or to be seen by an audiologist. Hearing aids are separate. They are for all ranges of moderate to, mild to moderately severe, and those are prescribed and dispensed by a licensed professional. You still need a note from your doctor and to see an audiologist to get hearing aids. I put this in there because these things are called personal sound amplifiers. At one point in my career, I lived in Louisiana, and this was like a lot of people would have these to like hear ducks or deers and other things when they would go hunting. These are not hearing aids. So hearing aids are small computers that can be programmed so that they increase the volume preferentially in the frequencies that are missing. You can see in this hearing test, which is indicative of both noise-induced and age-related, that there's more hearing loss in the high frequencies. So this individual, if you just turned up the volume on all frequencies, just literally universally turned up the volume, that would not be accurate for this person. The same way you buy glasses that may do that. These need to be fit to an individual's prescription, which in this case is the audiogram. So a PSAP, you often can't tell. Somebody might buy it off Amazon and it looks like a hearing aid. Even I can't tell some of the time, but in fact, it's not. It's much cheaper, but that's also because it's just universally amping the volume on all frequencies at the same time, just an amplifier. What about cochlear implants? Well, cochlear implants are surgical. This cochlear implant technology is really impressive, and it's based on a concept I mentioned earlier, which is 90% of hearing loss happens at the level of the cochlea and the inner hair cells. And for that reason, a cochlear implant can bypass and treat a tremendous amount of hearing loss by putting this electrode inside the cochlea. Individuals have one part that goes under the skin, one part on the outside that looks like a hearing aid, sort of, but is not a hearing aid. When the person's wearing it, they're able to take that sound down through the electrode and activate the auditory nerve, which is still working and still in place. People who are candidates for cochlear implants are those who don't get adequate benefit for hearing aids. This is a lot of what I do, cochlear implants, so if anyone would like to know more about that, it is the most successful neuroprosthesis to date, restores hearing loss, restores hearing in individuals, and has really tremendous implications for health and function, as sort of mentioned earlier. So basically, thus far in the lecture, I've described how hearing loss is widely prevalent, tremendous impact on health and function, and is highly treatable with very successful interventions. Now, however, only 16% of individuals with hearing loss use a hearing aid. Even fewer get a cochlear implant. Less than 7%. We used to say 10%. Now our new data says 7% of individuals with severe or those who qualify get a cochlear implant. Why? Why is that? And I will say many of you may be, if you're still paying attention to this Zoom lecture, may be having an idea about why that is, but I find that it might be more complicated than you think. So money, that's the first thing people say. And of course, that makes sense, right? Money, hearing aids are incredibly expensive. One of the great studies a while ago said it was the third highest expenditure for beyond a house and a car for many people who got hearing aids, which is just mind-boggling. It's often not covered by insurance, most notably not covered by Medicare, is covered by some commercial insurances. And for this reason is part of why the Over-the-Counter Hearing Aid Act bubbled up and became, through Hopkins and a lot of the work that they had done, passed in October of 2022. Now, some people might say this, and most of us are very enthusiastic and remain so about the Over-the-Counter Hearing Aid Act. You might ask, okay, what about places where hearing aids are covered? For example, in the VA system in the US, hearing aids are covered. In the National Health Service in England, hearing aids are covered. In both of these cases, they sort of take out to some degree the issue of cost. Now, what are the rates in those? You might say, oh, 50%, much better. Nope, roughly only a little bit better. I mentioned 10% and 16%. Some of the recent data there says 18%. So clearly it's not just an issue of cost. Notably, Hearing aids, not covered. Cochlear implants, because they are surgical and et cetera, they are covered. And in fact, only about 7 to 10% of those individuals are getting them. So there's a ton of barriers to care for this, and I'm going to go through as we finish up here in the next minute or so, just some of them. So first of all, there's a widespread idea that hearing loss is not treatable. Well, hearing loss is permanent. That, I hope, was gathered from some of the variety of causes, both noise-induced, aging, ototoxic, etc. But it is highly treatable. Less than 20% of adults think that hearing loss is treatable. Most people really have no idea about the treatment options. Many have not heard of cochlear implants, for example. And lack of evaluation. This is actually, I got a dog in December. She's very cute. I used to laugh at this study, and now I kind of get it, I have to say. But this is a study that actually showed that adults were more than twice as likely to take their pet to the vet just for a routine checkup to get checked than to get their hearing checked when they themselves suspected that they had hearing loss. So in fact, lack of evaluation is definitely something that's out there. This is a really important slide. So if you haven't paid attention or you're zoning out, but totally understand, ready for the weekend, this is something really important to take away, which is doctors don't ask their patients about hearing loss, and patients don't bring it up to their doctors. More than 80% of individuals who indicated that they were concerned they were having symptoms of hearing loss didn't bring it up with their doctor. So it's really one of those things that if you don't ask about, don't investigate, people aren't going to bring up. And then, of course, access, really important. Access to audiologists, to doctors, et cetera. This is just a heat map of audiologists across the US. So they are out there, but there are some highly underserved areas. Stigma, that's something that we have tried to write about, and the science there is, or the data is very apparent that there just is a lot of issues with the stigma of using hearing aids and the association, both with getting older and a variety of things. You will notice if you watch The Golden Bachelor, he did wear hearing aids, and hearing aids were extremely positively portrayed on The Golden Bachelor. I didn't watch the whole season, but I watched a few of them. If I probably shouldn't admit that, but anyway. Well, there is, some things are happening toward that end. And the last one is something that I would bring up, which is the language and the diagnostics we use to talk about hearing loss is incredibly confusing. Our specialty has done a really bad job of that. Probably everyone on this call, and there's a great amount of data to say, like, who knows, like you leave medical school, you know what good vision is 2020, even if you're someone, blood pressure, normal glucose. Most of us even know a normal BMI. No one has really any idea what is the number for normal hearing. Even if you got a hearing test, from one of your patients, to read a hearing test is kind of complicated, as I described. It's hard to know. Some are in the normal, some are not. It's a very confusing, and patients find it excessively confusing as well. And this is a new campaign coming out again of Hopkins Epi Department, which does a lot for hearing loss. And I hope that in the coming years, I'm part of this group in the Know Your Hearing Number. It's a way to improve the way people understand and talk about hearing, both doctors and patients, just to try to destigmatize hearing loss and empower individuals to talk about it and have a baseline understanding of what we mean when we talk about hearing loss. We know that hearing aid users wait on average 10 years before getting help for hearing loss. The numbers are even worse for cochlear implants, not surprisingly. And really, one of the underlying concepts here is that the impact of hearing loss on health and function is under-recognized and undervalued. And that's all of our jobs, to really help move that into a problem that can be discussed, destigmatized, and understood. So, of course, the best treatment is prevention. This is from NIOSH, which talks about a variety of controls that can be used to change things in the workplace. They actually have a great sound level meter app. It's free to download, and it was designed by some really impressive audio engineers. When patients ask me for decibel meters, I always recommend this one. It's really good. and in the App Store, et cetera. So really any person, of course, someone at work, but any individual could measure the decibels of their surroundings. This is one of the handouts we give in our office talking about different hearing protection. The foam earplugs that you can buy at CVS or any drugstore are really quite good. Of course, the over-the-ear, well, they're quite good if you can get them in their ear, in your ears, et cetera. I encourage people to just have some in their purse, in their bag. For those unexpected fourth grade band concerts in the cafeteria that may arise. And of course, for individuals at construction and others, they should be wearing these over the ear hearing aids. And the last concept is hearing health is just general health. It's brain health. You know, tobacco cessation is associated with better hearing, diabetes control, et cetera. You know, your ears are a barometer for your overall health. So making those healthy choices is really important. Okay, so in this whirlwind of hearing loss, I hope that we have covered a few things. First, noise-induced hearing loss is very common, affects the high frequencies first, and symptoms are often not hearing less. It's really important to ask patients about their hearing loss, recognize if they've had an acute loss or an acute change, and then proceed with treatment for that if possible. Overall, hearing loss has tremendous impact on health and function. We covered pretty much the gamut of things between cognitive decline, dementia, isolation, falls, et cetera. And then treatment is highly effective, both hearing aids, cochlear implants, and that's beyond just hearing better. I didn't present the data about people hearing better because frankly, that's not really data. That's been around for a long time. But the impact on health and function after treatment is what's very exciting. And of course, the best treatment is prevention. Well, that is it. Thank you all very much.